Seminar series conducted by the Center of Excellence, Regional Institute of Medical Sciences, Imphal. Today, we have a session on the topic Introduction to dolutegravir-based regimen and Phase 1 transition plan. And today's speaker is Dr. N. Biplab Singh. Dr. N. Biplab Singh, Fellow of Indian College of Physicians, Fellow of American Association of Physicians, Johns Hopkins Medical Fellow, he is currently working as professor in the Department of Medicine, Regional Institute of Medical Sciences, Imphal. He is a member of the State Ed's Clinical Expert Panel, SASEP of Center of Excellence, RIMS, Imphal. He has been working in the field of HIV/AIDS for the last many years and as a consultant of the RDLS Center since 2004. He was the honorary vice president of the API Manipur State Chapter and vice chairman of the Medical Society, RIMS, Imphal. He has been actively involved in treating HIV/ICV co-infected patients and presently working with discordant couples in HIV infection. He is also a trainer of NACO training conducted at RIMS Imphal. He had published many national and international papers and also attended many conferences, both national and international. So now we are presenting Dr. N. Biplab Singh on the topic Introduction to dolutegravir-based regimen and the Phase 1 transition plan. So over to Dr. N. Biplab Singh, sir.
Hello, good afternoon, everybody. Uh, so I'll try to be brief. This is a new molecule upcoming, and which is going to introduce in the NACO program. During my talk, I will try to give some information about the introduction of dolutegravir in the National AIDS Control Program. Why dolutegravir is important, what is the pharmacology of dolutegravir, and what are the benefits of this new molecule called dolutegravir. The DTG regime is in the first line, in the second line, and in the third line, how we are going to use this new molecule. There are subtle special situations like HIV, TB co-infection, and also in women where with the reproductive age group, how we are going to use this new drug in this population. And so also the using of the post-exposure prophylaxis of this new molecule dolutegravir, how we are going to use as a post-exposure prophylaxis in certain situations. Lastly, but not the least, the phase 1 of NACO dolutegravir transition plan. I will try to highlight briefly on this phase 1. We all know that there are so many classes of antiretroviral drugs. One group of drug is the nucleoside reverse transcriptase inhibitors, where a lot of drugs are already been in use, dadubudin, stabudin, lamivudin, abacavir, emcitrabine, etc. There are another group of molecules that is called non-nucleoside reverse transcriptase inhibitor. In this group, we have integrase inhibitors, that is raltegravir, and the new drug called dolutegravir, which has got a very high efficacy or high viral suppression. The other group of drug is the protease inhibitors. As we all know, it has been already in use for the last so many years. Lopinavir, ritonavir, atazanavir, darunavir, etc. This is this I will not go in detail. This is about the how the various antiretroviral drugs acts on different site in the inside the cell. Now, why dolutegravir-based regimen is important? There are a lot of important aspects for this molecule. One is the rapid viral suppression. The It achieves viral suppression sooner than the efavirenz, that is at the end of 4 weeks when compared to the efavirenz at the end of 12 weeks. So there is much higher or the earlier viral suppression when compared to efavirenz with the dolutegravir. They have got a very few toxicities or the side effects. There are minimal discontinuation, less than 2%. And when compared to the RASes, the development of RASes is hardly 2% in the dolutegravir versus 13% in the efavirenz group. There are also laser neuropsychiatric events, including dizziness, significantly much more less than the efavirenz, around 35%, but in dolutegravir it is hardly 5%. While insomnia was reported to be a little frequent with the dolutegravir, that is 13% versus 7% in a single study. What about the potency? This drug is a more potent regime which doesn't have uh, no known treatment emergent resistance across the trials. There are minimal drug interactions currently recommended to use in 50 milligrams twice daily when the patient is co-infected with tubercular infection using rifampicin. There are high genetic barrier, and it is effective against the HIV2 and also harmonization across the patient population. Now, this is one of the study which was published in the Journal of Acquired Immune Deficiency Syndrome 2015. This is a single study, ART-naive patients, 933 patients, and they try to compare the efficacy of two different regimes, one containing dolutegravir, abacavir, and lamivudine. Another one, the tenofovir, emcitrabine, and efavirenz, and they try to analyze the rate of viral suppression at the end of 48 weeks and 96 weeks. It has seen that the dolutegravir containing regime has got 88% versus 81% at the end of 48 weeks, and also 80% versus 72% at the end of 96 weeks. Therefore, it shows that the dolutegravir regime has shown that a higher rate of viral suppression. When we compare with the efavirenz alone with the dolutegravir, it has seen that it has already mentioned that the dolutegravir has got a rapid viral suppression at an average of a period of 4 weeks when compared to 12 weeks with the efavirenz. This is the graphical presentation of this study. This is a triple study, and the yellow line shows those population who are using the tenofovir, emcitrabine, and efavirenz, and the blue line above it, it shows that the population which are using the dolutegravir, abacavir, and tenofovir, lamivudine. So it has been seen that when we look into at the end of 48 weeks, at the end of 96 weeks, it has seen that the rate of viral suppression, viral HIV RNA less than 50 per ml, is higher in the dolutegravir combination group. This is about how well it is tolerated in these two groups. They try to analyze that the dolutegravir versus the emcitrabine group for the discontinuation of the drugs. At the end of 48 weeks and at the end of 96 weeks, it has seen that 2% of the dolutegravir group versus 10% of the emcitrabine group discontinued at the end of 48 weeks because of the adverse events. Likewise, the dolutegravir regime has got a laser adverse events, and the laser rate of discontinuation hardly 3% compared to 11% at the end of 96 weeks when compared to the emcitrabine group. The what about the barrier and resistance? We know that dolutegravir has got a higher barrier to the resistance. No integrase inhibitors and nucleoside reverse transcriptase inhibitor resistance to 48 or 96 weeks with dolutegravir. Another study has shown that this is also almost same, the 48 and 96 weeks with the dolutegravir. And as another single study, 484 patients, there is no imminent the integrase inhibitor or nucleoside reverse transcriptase mutation at the end of 48 weeks with dolutegravir. So treatment experience with the integrase naive 715, there is fewer resistance mutation with the dolutegravir when compared to raltegravir. Hardly 1% have the resistance mutation compared to raltegravir. At the end of 48 weeks is around 5%. Now, when we look into the potency and the genetic barrier to the resistance, we have so many drugs which has been already been in use, like the zadobudin, stabudin, then tenofovir, then abacavir, then emcitrabine, nevirapine, ralpivirine, efavirenz, so and so. So when we look into the barrier to resistance and also the potential, of all the drugs, the dolutegravir has got the highest barrier to resistance and the highest potency when compared to the other drugs. Now, what is the current data about the dolutegravir in pregnancy and newborn? And there is one study, call it Botswana Sarpamo study. It took place at height of the largest maternity ward in Botswana, around 45% of the total birth in the country. The early analysis by 2018 identified that 4 neural tube defects out of 426 women who are using dolutegravir at the first time of conception. But it has been updated by 2019 that it has shown that it is declined. It is declined to 0.30 of these 426. The woman on efavirenz at the conception in some of the studies has shown that the neural tube defect risk is high, that is 0.05, often reaching to 0.15. The other antiretroviral drugs have had also risks for this type of defect up to 0.21%. However, it is safe to initiate dolutegravir-based regime in pregnant women if it is beyond the first trimester of pregnancy. Now, what is the risks and the benefit of dolutegravir used if we use in the women with childbearing potential? The benefit of dolutegravir in the woman with childbearing potential includes a greater maternal viral suppression, a fewer maternal death, few sexual transmission, and also fewer rate of mother-to-child transmission. The risks of dolutegravir in the woman with childbearing potential includes the morbidity resulting from dolutegravir-associated weight gain, and also neonatal death among the infants of pregnant women with dolutegravir, which is associated with weight gain. The risk benefit model suggests that the benefit of dolutegravir in people with women with childbearing potential, uh, newly initiating antiretroviral therapy, likely overweight the risks associated with it. The blanket exclusion that deny women equitable access to the optimal HIV treatment with dolutegravir are not warranted or justified. Uh, what about TLD and adult women and the adolescent girls for childbearing population? The effective contraception should be offered to adult women and the adolescent girls of childbearing age. The dolutegravir can be prescribed for adult women and adolescent girls of childbearing age and potential who wish to become pregnant and who are not otherwise using or assessing consistent or effective contraception if they have been fully informed of the potential risks of the development of neural tube defect. In case if the woman does not want to initiate the dolutegravir regime after adequate counseling, she should be initiated with the tenofovir, lamivudine, and efavirenz. If the woman is identified to be pregnant after the first trimester, dolutegravir should be initiated or continued for the duration of the pregnancy. Now, what are the adverse events and the drug interactions with the dolutegravir, which is very, very important. Now, it's already mentioned that insomnia is slightly uh, more common with the dolutegravir. It is around 13% when compared to the 7% with the efavirenz. Then headache, dizziness, tiredness, allergic reactions, hardly 2%. It's better than the efavirenz. And the dolutegravir associated weight gain is common if we use this molecule. So WHO recommended that the importance of a healthy diet and also regular exercise and the principle for managing the maintaining the weight. Now, there are some important drug-to-drug interaction with the dolutegravir. In this era of COVID, I should mention this particular drug. There are a lot of people who are taking antiretroviral drugs, and they might be thinking that I am a immunocompromised patient, and without proper knowledge, they might be thinking that if I take the hydroxychloroquine, that is amodiaquine, one of the amodiaquine, which can prevent the virus to come inside their body. So this is one of the fear of, from my point of view, that we should not take without proper directive from a doctor. The amodiaquine has got a quite the drug interaction with the patient using dolutegravir. There are also various drugs like carbamazepine, phenytoin, which are very commonly used for the anticonvulsant. They also has got a drug interaction with the dolutegravir, and so we should try to change the drug if the patient is put on to dolutegravir. Now, dofetilide, this is another anti-arrhythmic drug which are used in the arrhythmias, cardiac arrhythmias, and this also has got the drug-to-drug interaction with the dolutegravir. So preferably it should be avoided when if the patient is put on to DTG regime. Another very common which we come across is that even maybe with the disease process or with the using of the drugs like protease inhibitors, we know that many of our patients are having diabetes, development of diabetes, and they are put on with metformin. Now, if these populations who are already having diabetes and put on metformin uh, with a dosing schedule of more than 1,000 per day, it should be avoided because it has got a drug interaction with this
newer molecule, that is dolutegravir. There are also many polyvalent cations, products which are very casually used by the doctors or even by the patient himself by self administering these of the drugs, that is aluminum, calcium, iron, magnesium, and zinc, which are in the composition of antacids, multivitamins, and supplements, thinking that they will improve their health. They has got drug interaction with this new molecule, that is the dolutegravir. So if at all, if somebody wants to use some of the drugs, some of the vitamins or some of the antacids or some of the food supplements uh, with these drugs, they should be used after 6 hours of uh, in, uh, using the dolutegravir. Rifampicin, it reduces the drug level of the dolutegravir to less than 50%. So that is why those patients who are taking antitubercular drugs with rifampicin, the use of the dolutegravir should be double the dose, that is the 50 milligram twice daily. In case if the patient is using rifabutin, then we can give only 50 milligram once a day. Now, how dolutegravir is proposed to be used under the national program? This DTG regime to be implemented after the release of peace memorandum from the NACO. Now, what is this transition to dolutegravir based regime in phase 1? The dolutegravir based regime for treatment of HIV positive adolescent and children weighing more than 20 kilograms and the age more than 6 years. This base regime will be the preferred regimen in the national program for the new PLHIV patients or who are already on the antiretroviral therapy. The selection of appropriate dolutegravir-based regime would be depend on the viral load suppression status of the PLHIV patient and also current ARV drug being used. There are various ARV regimes which will be gradually shifted to dolutegravir-based regime in a phase-out manner. The transition plan would be based on the drug stock availability. NACO would be issuing office order from time to time for transition to this dolutegravir regimen. Now, what are the upcoming guidelines? The first line ART regime in ART naive adult and adolescent. The preferred, if the age is more than 10 years and weight more than 30 kilograms, tenofovir, lamivudine, and dolutegravir 50 milligrams. This is fixed dose and should be taken once daily at bedtime or any fixed time every day as per the patient's convenience. It can be used in HIV-1, HIV-2, HIV both 1 and 2, and also in women who has been already exposed to a single dose of nevirapine in the past, and also with the PLHIV co-infected with tuberculosis, hepatitis B and C. Women of childbearing age potential should be provided the informed choice about the benefit and the risks of use of dolutegravir containing regime so that they can choose which regime they would like to use for themselves. So PLHIV with a body weight of less than 30 kilograms, we cannot use tenofovir, as we all know that. So abacavir should be replaced in place of tenofovir and lamivudine and with the dolutegravir of 50 milligram once daily. Now, all the patients with the above the upper level off normal or a high or a higher level of serum creatinine values, we should try to adjust the dose of lamivudine along with abacavir and dolutegravir, need not to reduce the dose in such a case. And this is for the people with on antitubercular drugs containing rifampicin. As already mentioned, that the dolutegravir should be given twice daily, that is 50 milligrams twice a day, along with tenofovir and lamivudine. Females in the reproductive age group, as already mentioned, that we should explain nicely about the adverse effect of neural tube defect and also weight gain. And if the patient is opted, then we can go for it. But if the patient is not opted for the dolu containing regime, then they should use for the tenofovir, lamivudine, and efavirenz. In case if the efavirenz is contraindicated, then the prior NNRTI exposures are there, then in that situation, what we have to do is we should give tenofovir, lamivudine, and ritonavir boosted lopinavir. Now, what are the upcoming second line regime? Suppose a person who has already been exposed to zadovudine containing regime and it has failed. Now, what is the second line of choice? That is tenofovir, lamivudine, and dolutegravir. If tenofovir is contraindicated, then we can use abacavir. In those patients who has already been exposed to tenofovir and abacavir containing regime, and if it fails, the second line of drug is zadovudine, lamivudine, and dolutegravir. In case if the hemoglobin is less than 9 gram %, then we should go for dolutegravir and ritonavir boosted lopinavir. In those patients who has already been exposed to tenofovir, lamivudine, and dolutegravir, in this situation, if it is failed, then we should use as a second line the ritonavir boosted atazanavir and zadovudine and lamivudine. In case if the hemoglobin is less than 9 gram %, then we should increase the dose of dolutegravir to 100 milligrams along with ritonavir boosted lopinavir. If the patient is already been exposed to zadovudine, lamivudine, and dolutegravir, in that situation, we should go for ritonavir, atazanavir, and tenofovir and lamivudine. There are certain situations in some of the patients that they had been exposed to the multiple NRTI and also NNRTI based first line regime. If they fail, then we should go for ritonavir boosted lopinavir along with dolutegravir, 50 milligrams a day. In certain situations where there are multiple NRTI exposure and also PI based first line, and if they fail, then the second line regime of choice will be ritonavir boosted darunavir and dolutegravir of 50 milligrams a day. Any PL-HIV co-infected with tuberculosis should receive twice daily dose of dolutegravir until the patient completes the ATT. Any PL-HIV co-infected with hepatitis B will receive additional tenofovir and lamivudine if not already received. Now, third line ART. What are the third line ARTs? The third line regimen should include new drugs with minimal risk of cross resistance to previously used ARVs. The third line ART will be formed by INSTI and a new boosted PI. The third line ART will be started by ART centers after receiving advice from SASEP. The regime and dose is the dolutegravir 50 milligram twice a day with ritonavir boosted darunavir. Dolutegravir will be used once a day if the drug was never used in the first or the second line ART regimen, and any PL-HIV co-infected with hepatitis B will receive additional tenofovir and lamivudine not already who has not already received. Now, what about the upcoming guidelines for the children with HIV? Now, if the weight is 20, less than 20, and the age is below 6 years, the recommended regime is abacavir, lamivudine, and ritonavir boosted lopinavir. And if the weight is between 20 to 30 kilograms and the age is between 6 to 10 years, the drug of choice is abacavir, lamivudine, and dolutegravir. If the weight is above 30 kilograms and age above 10 years, we should use tenofovir, lamivudine, and dolutegravir. Now, this is also upcoming guidelines in the children's, in the patients with HIV-TB co-infection in ART-naive children's. If the weight is less than 20 kilograms and age below 6 years, abacavir, lamivudine, ritonavir, boosted lopinavir, and should be used. And if the weight is between 20 to 30 kilograms and the age is between 6 to 10 years, the abacavir, lamivudine, and dolutegravir with an additional dose of dolutegravir 50 milligrams in the evening should be used. In patients whose age is above 10 years and the weight is above 30 kilograms, we can use tenofovir instead of abacavir with lamivudine and dolutegravir with an additional dose of dolutegravir in the evening if the patient till the antitubercular drug is finished. Now, what about the recommended PAP regime, upcoming guidelines? The doses of drugs for the PAP in adult is tenofovir 300 milligrams, lamivudine 300 milligrams, and dolutegravir 50 milligrams. One tablet immediately within 2 hours of the exposure, either at daytime or at nighttime. The next day, one tablet once daily should be continued for 4 weeks. Now, what about PEP drugs in the children? 3-drug regimen given in a dose as per weight band. The zadovudine, lamivudine is recommended as a preferred backbone for HIV PEP for children. The abacavir and lamivudine is also advised in children once the hemoglobin is less than 9 gram%. Tenofovir, lamivudine can be given if the children is beyond 10 years and if the weight is more than 30 kilograms. The third drug option is the ritonavir boosted lopinavir for the children who are less than 6 years of age and the weight is 20 kilograms. Less than 20 kilograms. And those children who are having more than 6 years and weight more than 20 kilograms, the dolutegravir can be given as the post-exposure prophylaxis regime. Now, what is this phase 1 transition plan? Here, they divide into 4 groups of patients. The first one is the all patients currently on the raltegravir-based regimen. The second one is the patients who need to be switched to third-line ART or to alternate second-line ART, that is dolutegravir, will be the preferred integrase inhibitor instead of raltegravir. Now, if the patient is on raltegravir and ritonavir boosted lopinavir, the most important is the viral load. If we see the viral load, if the viral load is less than 1,000 copies per ml, or if the target is not detected, In this situation, we can go for ritonavir boosted lopinavir with, instead of raltegravir, we can go for the dolutegravir 50 milligram once a day. In case if the viral load is more than 1000 copies per ml, then we should go for ritonavir boosted darunavir with the dolutegravir. It should be given twice a day. The another subset of population, that is, which are already in use of raltegravir with ritonavir boosted darunavir. If the viral load is less than 1000 copies or TND, in that case, we should give ritonavir and boosted darunavir along with the dolutegravir of 50 milligrams. If it is more than 1000 copies, we should increase the dose of dolutegravir to 100 milligrams per day. The third group of patients is who has already been exposed to the multiple NRTIs, and also there is a virologic failure and who need a second line initiation. In this situation, the recommended regime is the ritonavir boosted lopinavir and also the dolutegravir of 50 milligram once a day. The fourth population is the second line failure on 2 NRTI and using also PIs who need a third line ART. In this situation, we have to go for ritonavir, boosted darunavir, along with the dolutegravir of 50 milligram once a day. Now, monitoring and follow-up of PL-HIV on the second line, body weight, treatment, and clinical monitoring of OIs, TB, or staging should be done for every visit. The laboratory evaluation and CD4 and viral load should be done at the end of every 6 months. Now, what is this DTG transition? Important points for the ART center. The available stock of raltegravir shall be utilized first. The dolutegravir in BD doses for HIV TB patients, and also those PL-HIV on rifampicin base on ATT should be given twice daily dose. The dolutegravir once daily dosing for the children's in case if the weight is more than 20 and if the age is more than 6 years. Now, what about viral load testing for the dolutegravir transition? Viral load testing already on ART, the viral load testing should be done before transition to a new regime. And if the viral suppression is there, all the transitions to be done after a single suppression of viral load less than 100, less than 1000 copies. Viral unsuppressed more than 1000 copies, patients should undergo enhanced adherence step of counseling for 3 months while continuing the same regime, and the patients who have adherence of more than 95% for conducting a second viral load testing. This is the note for the counselors at ART centers. All the PL-HIV transition to dolutegravir based regime should be counseled and informed about the rationale for transforming to the new regimen. They should be explained properly about its adverse effect and its weight gain, its neural tube defect, etc., etc. There are also the prescribed, the dolutegravir can be prescribed for the adult women and adolescents for childbearing potential who wish to become pregnant. We should inform about the risks of developing neural tube defect and also weight gain. If a woman is identified to be pregnant after the first trimester, there is no harm in giving dolutegravir uh, throughout the length of the pregnancy. The counselor should explain the benefit of dolutegravir, greater maternal viral suppression, and fewer maternal death, fewer sexual transmission, and also fewer mother-to-child transmission for the women of the childbearing age group. Now, capacity building for the ART center staffs. Training for ART, SMO, MO should be done through platform like NDLS, RDLS, telemedicine, Zoom, Eco, etc. In this scenario of lockdown due to COVID-19, the respective online classroom session for blended clinical training curriculum are being modified. One-day training of all the concerned ART staff like care coordinator, counselor, pharmacist, data manager should be conducted. Online materials will be uploaded on NACO website for referral. Printed IEC material under development for ART staff. Job aid ready Recona for MO on ARV regimen transition, drug interaction, flip card, checklist for the counselors should be provided. Patient information sheet for education or PLICV on dolutegravir regime are under development. Revised recording and reporting format will be shared with all the SACs, COE, or ART centers soon. Any queries, I'll be happy to answer. With this, I would like to say thank you to everybody.
Anybody having any queries, they can unmute themselves and ask the query. Thank you.
Very nice and very useful presentation. Congratulations. Thank you very much.
Thank you. Thank you.
Excuse me, sir.
Yes.
We have a question from the counselors at the center, RIMS, sir.
Yes.
Like, for example, if a woman has started on the, she wants to start as her choice of drug on dolutegravir, so later on, if she wants to go for pregnancy, can the regime be changed back or should it be changed back?
Ideally, what we have to do is during the first trimester, it is not recommended to give dolutegravir. So if she wants to choose the regime containing dolutegravir starting from the first trimester of pregnancy, she has to take the risk of having development of neural tube defect. That she has to understand. Secondly, about the weight gain. So this is up to the choice of the person or the woman with childbearing potential. If she wishes to take, she can take the risks and continue the medicine. But in case, if from our side, we should be given the freedom to choose which drug, which regime would you like to prefer to take. If it is after second trimester, after the first trimester, it can be given safely from second trimester up to the whole length of pregnancy with dolutegravir. So I think it should be given, the choice should be given to the, but you cannot change here and there. Once you start the regime, you cannot just change the regime, because if you change to efavirenz, we know that the viral suppression is at the end of 12 weeks. But dolutegravir, we know that I have already shown in my slides that the dolutegravir has got a rapid viral suppression at the end of 4 weeks. At the same time, the adverse events are much more higher with the efavirenz. If you are going to have a pregnancy for a longer period. So this should be the choice of the patient. We should put in front which it has got this much adverse effect, it has got this much adverse effect. So which one would she like to prefer for continuing the antiretroviral therapy during the pregnancy?
Thank you, sir.
Hmm.
Yeah.
Any more queries from anyone?
Thank you, sir. That was Dr. Biplab Singh on Introduction to dolutegravir-based regimen and Phase 1 transition plan. So once again, we thank you all the participants for your kind cooperation. Thank you.